Good morning, good afternoon, good evening, everybody. I'm Erica Nybro. I'm the COVID-19 technical lead at Knowledge Success, which is a USAID-funded project, and we've been working on COVID-19 activities for the last year or so. This is our third and final webinar in a series on integration of COVID-19 vaccination into primary health care. We are focusing today on generating demand for COVID-19 and other life course vaccinations. And we're going to be hearing examples from 3 different countries in really 3 regions across the world. Next slide, please. Before we begin, please note that we have interpretation in French and Portuguese available today. We ask all participants to select your preferred language, either English, French, or Portuguese, by clicking on the globe icon at the bottom of your Zoom screen. Because we are providing live interpretation today, we've also asked all of our speakers to speak a little more slowly than usual and to pause between transitions just to give our translators time to keep up with us, especially with all of the technical language. I'd like to take a moment to introduce the incredibly highly experienced panel of experts we have with us today. Gloria Lihemo serves as the SBC specialist at UNICEF, and she's going to be giving us some introductory comments today to help frame our conversation. Then we're going to hear from Saratu Olabade Ojo. She's the chief of party at Breakthrough ACTION Liberia, where they've been doing a whole lot of COVID-19 activities, especially around demand generation. Then from MRIGHT and JSI, we have Lisa Oot, Senior Technical Officer, and Stefan Mandic-Rajcevic, SBC Consultant for Serbia and the Eastern European region. So I think it's going to be really interesting to hear experiences from that region where we don't always focus so much of our attention. And finally, Dr. Roma Solomon is the India Director for the Core Group Partners Project. So we're going to start today with opening remarks from Gloria Lihemo. I want to note that after each presentation, we're going to go from each presentation to the next. Please note any questions or comments you have in the chat, and we do have time reserved at the end of the session for Q&A for any of the presenters and discussion. And then I'll close with a few final remarks by 9:30. So with that, I'm going to invite our first speaker, Gloria Lihemo, to share some opening remarks. Over to you, Gloria.
Good morning, everyone. Good afternoon or good evening, wherever you are. Thank you, Erica. I'm going to start by reflecting on some of the considerations that underpin integrating COVID-19 from a demand promotion perspective. Next slide, please. Yeah, so just to kick us off, some of the considerations that we are and or should be looking at are, for example, reaching priority groups like the elderly and the people who are immunocompromised still remains a major challenge even now in a post-pandemic era. And so to reach these groups, immunization programs need to build engagement with a range of new primary healthcare program partners. We're talking about reaching people with diabetes and nutrition centers, working with non-traditional partners like the aged care and social services. And also at the global level, integration will necessitate having stronger coordination by funders and implementing agencies to ensure that the resources for integration are not fragmented and that budgets, funding flows, and results frameworks are not siloed along specific programs, but that rather we are designing to support integrated programming. Secondly, there's a whole issue around resources for integration, even from a demand perspective. We know that there's a higher cost of delivering vaccines where no routine services are available. Experiences from the introduction of other vaccines like HPV have demonstrated that the cost of delivering vaccines to an age group that is outside of the under 5 childhood immunizations is much higher. This increase in the delivery cost, of course, constrains the resources that are available for outreach and other community mobilization activities. That said, integrating complementary demand interventions is also not new. I mean, vaccination demand interventions have been combined with vitamin A interventions, with deworming, with insecticide-treated nets interventions, and similar interventions. So all of this underscores the importance of positioning COVID-19 vaccination as part of a wider health agenda, whether that is primary healthcare, universal healthcare, the decade of healthy living, and healthy security. Next slide, please. So we recognize that there are challenges in integrating COVID-19, but we know that there are also opportunities for us to strengthen community structures and other demand-related systems to support primary healthcare. So integration across life course is the future of immunization. There's increasingly new vaccines being administered beyond childhood, like malaria vaccines, TB vaccines, and all of this will require new methods and approaches to reach the different priority groups. A key challenge is that most countries, especially in low and middle income settings, do not have systems for evidence-based decision-making around life course immunization. There's limited data. We know that even though life course interventions, where they exist, even in some lower middle income countries, are very siloed and with very limited resources. We also have to recognize the fact that communities have many competing demands. So it's important to understand what is feasible to integrate and prioritize that in our interventions. Equally important is tailoring our demand strategies to meet the heterogeneity of priority groups. By designing interventions that can be administered through diverse delivery platforms for different age groups and with different needs across the life course. We also need to think about how we communicate about integration. We need clearer messaging on acceptance by communities and to also present evidence in a compelling and people-centered way so that we're able to encourage priority groups to value and seek recommended vaccines. Next slide, please. The Global Vaccine Demand Task Team has developed a framework to guide countries in their integration efforts. The framework is based on insights from consultations and interviews conducted with countries based on their experiences on conducting demand for vaccination, for integrated vaccine services. It provides tools and examples to support strengthening of demand integration framed around building blocks for vaccination demand. It also identifies entry points, documents lessons learned. It documents lessons learned and best practices. And it also includes tools to measure progress and relates theory to actual practice. Next slide, please. So these are just some examples of the building blocks that are highlighted in the framework. So we know, of course, that robust social and behavioral research and data is fundamental to tailoring of demand interventions for specific priority populations. The framework recommends using tools such as the Behavioral and Social Drivers, BSD tool, human-centered design and social listening to understand context-specific behavioral implications for integrating COVID-19 vaccination. Additionally, countries also need to advocate for the regular inclusion of social and behavioral indicators into large-scale surveys like the demographic health surveys, as well as which can also be a very cost-effective way of obtaining national and regional representative data to help us in guiding our program design and to track trends over time. And as far as coordination and planning is concerned, countries need an evidence-based integrated national communication strategy that is costed and includes cost and implementation work plans so that we avoid fragmentation and to facilitate the allocation of funding across health sectors. One of the priority investments that is needed here is to engage communities in micro-planning and co-creating local solutions to address barriers to uptake of integrated services. One of the main lessons that we learned from the introduction of COVID-19 vaccines was not to assume that all health workers accept vaccines. Integration can be an opportunity to engage health workers as trusted messengers, using holistic and empathetic approaches to address benefits and values of COVID-19 vaccination as part of a wider package of services. And finally, engaging communities with an equity lens by addressing the complex social economic barriers to uptake primary healthcare services like gender is very important. Communities and health workers should be consulted not only in identifying these barriers, but also in co-designing solutions to address equity gaps in immunization, including using approaches such as cash transfers and advocacy for better social security overall. Next slide, please. So we've included a slide here with some of the resources that countries can plug into with regards to integration as pertains to demand, including the operational framework that I just referenced a little bit ago. Thank you so much for listening, and this is a good segue to listen to practical examples from the countries. Thank you.
Thank you so much, Gloria. And I do think that we're going to notice from each of our next speakers various examples of those building blocks for demand integration. I want to highlight again, I think this operational framework resource is really incredibly helpful. I know that some of the teams that I work with have been referencing this tool. I really encourage you all to check it out. And I note here that it's available and will be available in French shortly. Thank you again, Gloria. I'm going to turn it over to Saratu Olabade Ojo. She's going to be sharing with us some of the really, I think, unique and creative ways that the Breakthrough Action team in Liberia has been integrating demand for COVID-19 vaccination into their work for other vaccinations, but also just for other health services in general. So over to you, Saratu.
Thank you, Erica. And hello to everyone. Thank you for the opportunity to speak to you about our efforts and how we support the government of Liberia to generate demand for COVID-19 vaccine. My name is Dr. Saratu Olabode Ojo. I'm the Chief of Party for Breakthrough Action Liberia. Today, I would share reflections and a few lessons on how we were able to generate demand in Liberia. Next slide, please. So I'll walk us through providing an overview of Breakthrough Action Liberia's COVID-19 activities. And we'll look at 3 strategic approaches that we used, looking at coordination to manage rumors, using interpersonal communication to address vaccine hesitancy, and then supporting community-led community engagement. And then we'll talk about the lessons learned from using these approaches. Next slide, please. So just a brief overview of Breakthrough Action Liberia. So Breakthrough Action itself is USAID's flagship social and behavior change intervention. The Liberia country buy-in started in April 2020 with a mandate to improve positive behavior change across a number of health areas, including COVID-19 vaccines. In Liberia, for COVID-19 vaccine uptake, we work in 7 counties, which are Grand Jide, Bong, Magibi, Grand Cru, River G, Bomi, and Grand Cape Mount County. You can see that highlighted in the map on the presentation. Now, to be able to achieve a lot of these activities, we work very closely with a number of both government and non-government partners. With the government, we work across several line ministries, including health, education, agriculture, youth and sports, and we work with other implementing partners to deliver COVID-19 vaccinations in these counties. And then Breakthrough Action focuses on strengthening capacity to use social and behavior change to improve and increase immunization rates. Next slide, please. Okay, so let's look at the first approach that we used. The first batch of vaccines arrived in Liberia in March 2021. Now, during that time, the period was an evolving period. We had an evolving situation as several partners and the government came together to increase, to create public awareness and increase uptake of COVID-19 vaccine in the country. Two priority groups were identified. We had the high-risk groups, which focused on the elderly, those with comorbidities, and as well as healthcare workers. There was initial hesitancy about the COVID-19 vaccines due to a number of reasons. Now, if you look at the slide, you would see some of the feedback that were received from healthcare workers. I'm not sure the vaccine is safe. The vaccine kills after 2 years. Let the politicians first take the vaccine and prove it is safe before I take the vaccine. Now, some of this hesitancy was as a result of previous history here in Liberia. For instance, adult vaccination is not common, nor is it widespread. And the COVID-19 vaccination was targeting an adult group. Prior to that, there was no prior communication to healthcare workers and the high-risk groups about the vaccine. Since this was a rapidly evolving situation, a lot of partners were brought in and the guidance was being developed and changed as the needs emerged. It was also further complicated by previous experience around Ebola, the history of the country with Ebola, where several healthcare workers lost their lives due to the disease, also worsened the hesitancy. There were also further complications when there were issues around gaps in service delivery or with stock out of commodities and medicines. That also fueled issues around the hesitancy of the vaccine. So Breakthrough ACTION's mandate was to increase public awareness and promote COVID-19 vaccination within this situation. One of our first approaches was to ensure that close collaboration with partners, both in the government and outside the government, was necessary to ensure that there was standardized provision of the vaccines through the demand creation process. So what did we do? We prioritized coordination and joint activity planning across all partners. We did this by developing closed WhatsApp groups, opportunities where partners came together in closed groups and we could have frequent discussions, meetings, and also standardized talking points about the benefits of the vaccine, where it was provided, who benefited from it, and then also standardized materials. We worked closely with the government of Liberia, the Health Promotion Division at the Ministry of Health, to ensure that all materials and messages developed for COVID-19 vaccine were vetted and signed off and released by the Ministry of Health, so that there were no multiple versions of materials going out. Now, what was the lesson here? It helped to build trust. It helped to rebuild the trust between the health system and the community. It also helped to align demand generation efforts with other partners working in the service delivery space as well as the supply chain space, so that we ensured that as we were raising demand for the vaccine, that there were other components of the vaccine, such as availability of the vaccine, access to vaccinators were also readily available to the people. Next slide, please. Now, the second approach that we used was the interpersonal communication to address vaccine hesitancy. Now, in creating demand, in the previous slide, we talked about the efforts to increase awareness, address issues around rumors, and then to also standardize talking points so that we had one voice. In our second approach, by September 2021, the government of Liberia was aiming to vaccinate up to 40% of the population by March 2022. Now, due to the hesitancy that was happening within the adult population of high-risk adult population, as well as with the healthcare workers. The government of Liberia opened up the vaccination to reach the entire population eligible for the vaccines. Now, it meant that the vaccine hesitancy became widespread across the entire country, which was also disrupting routine services, because then the COVID-19 rumors were also affecting other areas of health service delivery. So Breakthrough Action's mandate was to evolved from vaccine awareness to direct promotion and advocacy to the vaccine among priority areas. We did this by creating an enabling environment within communities, both at the national and subnational level and the community level for the COVID-19 vaccine. This was done through engaging with influential community leaders so that they had a voice to support the vaccine. Prior to their engagement, most influential leaders were not talking openly about the vaccine. Now, if we look at the slide, we would see different building blocks that we worked with. First was to ensure that we were engaging the right people, that we were talking to the right people, which is at the lower block. And then we were also ensuring that we were using the right channels to reach the right people. So a crucial example was the influential community leaders who are gatekeepers of their communities and influence positive behavior change in their communities. Engaging them meant that we had several advocacy meetings with them and discussions. It also included using different communication channels, also such as radio spots and interpersonal communication between those advocacy leaders and their community members. We trained them on how to speak to their community members so that, through speaking to them, they could also share their personal testimonies and encourage that two-way communication that encouraged them to, while they provided the right information on directing people to where to take up the vaccine, that they also had their concerns addressed. So sparking dialogue was critical here in Liberia. Other leaders that we also reached out to was also ensuring that we were engaging with the media professionals, both at the national and subnational levels. Then crucial also was we worked through the One Health, the multi-sectorial One Health risk communication and community engagement technical working group, which has a structure at both the national and the subnational level. The group is made up of communication specialists and stakeholders from different line ministries, agencies, implementing partners, the media, civil society groups. So they were instrumental in ensuring that they reached out to additional people regarding the vaccine. Next slide, please. And then lastly, the approach that we used was the community-led community engagement. Now, as Gloria had described earlier, the issues around resource management and the difficulty in ensuring that even as you're creating demand, that you're reaching, the right people, even in hard to reach places. So our community engagement approach leveraged on the influential community leaders. How did we use their networks, to ensure that through them, we're able to reach additional people through the networks. So we supported a robust community engagement approach, expanding to new populations through the network of influential community leaders. So as the vaccine target increased, it became essential to focus on those new areas. For Breakthrough Action Liberia, we worked with the community leaders to identify areas that had not yet benefited from the vaccine. So where we had high populations that had not received the vaccines, these were identified. We oriented the community leaders on COVID-19 vaccine, also trained them on interpersonal communication skills, as I mentioned earlier. And we provided non-financial incentives. We have two of them projected on the screen. One was the vaccine ambassadors. Now, for the vaccine ambassadors, they are influential leaders that have a voice in the community. One of the criteria was also to identify trusted leaders, that people, listened to their voices, and they had a good standing in their communities. So working through them, they were able to share their personal testimonies and engage with their communities and other, lower down leaders in their communities regarding the COVID-19 vaccination. So you can see one of the results was over 130 pastors, chiefs, religious youth leaders, and women leaders, transport union, and health workers were trained as vaccine ambassadors. And they conducted over 200 community engagement sessions. One of their critical roles was also to link their community members to the service delivery points, or to inform them about the community vaccination exercises, the dates that they were happening, so that community members were available to receive their vaccine. Another approach that was used was the use of street performance theaters. In West Africa, storytelling through drama, music, and discussions it's a common form of providing appropriate information here. So working with local street theater groups and drama groups in each community and their counties, and with support from the county health team and the health facility healthcare workers, as well as the community health assistants in that county, were able to develop talking points and a script for the theater performance groups. So over 24 performance groups were performed to debunk rumors and to promote ITN use. One of the main rumors that was going around was that the COVID-19 vaccine, the COVID-19 virus itself had been used on the mosquito net. So people shouldn't use the ITNs because they had the COVID-19 virus and they could get it in that way. So it was using the street theater performances in marketplaces where people congregated. It was an opportunity to provide appropriate information, to address concerns, and then to also spark conversation between the health service providers that were supporting the event and the community members available at the event. Next slide, please. So what were some of the lessons learned? I think for us, it was three main lessons I'll be discussing. First, starting that about the issues around rumors. So rumors do spread very fast, especially in closed communities with very close links and contacts. So it was important to prioritize a multisectorial approach and to ensure there was coordination between the different stakeholders involved in that multisectorial approach. As I discussed earlier on, it was a rapidly evolving period when the first set of vaccines arrived. And during that time, we were still in the process of developing the national guidelines, which would normally take time. So as a result, Breakthrough Action prioritized coordinating with key partners, both at the national and subnational level. The frequent communication sharing ensured that partners knew what each other was doing and were able to collaborate better, flag issues and concerns, and address it together to ensure that there was no duplication of effort. Another key lesson is that the role of interpersonal communication in ensuring uptake and integration of COVID-19 vaccines within, the routine service delivery in the country. So there were multiple voices that needed to be heard and needed to be considered. Using an interpersonal communication approach ensured that although those voices were heard and considered, that it was brought together to ensure that there's a central key message from one single outlet to ensure standardization of messages. This reduced the misconceptions, it reduced the hesitancy, and it reduced the rumors. So one of the key actions taken was to disseminate those key messages, work with the influential leaders to contextualize the messages, standardize the messages before they were circulated. And then lastly, community leaders are they're a very valuable resource with limited resources, and then looking at the hard to reach areas that needed also to get the COVID-19 vaccine. A crucial way of doing this was through community members, ensuring that expansion happened through them, which also increased the acceptance of the vaccine and reduced hesitancy. So working through gatekeepers at the community level, gatekeepers at the county level, and gatekeepers at the national level to ensure that they understood the benefits of the vaccine. They also had the appropriate information and about the and connections to the health service delivery, so that they could also have their concerns addressed, was crucial. Working also through the media, ensuring that the radio stations were involved. There are a lot of community radio stations, and those radio stations were adequately linked to the health system, was also crucial during expansion of vaccine messages, as well as addressing rumors. Next slide, please. So if you follow, so I'm just sharing additional resources with you to see some of the work and examples from Breakthrough ACTION Liberia on how we worked closely with the government of Liberia, as well as with other implementing partners, with the communities also, to ensure increase in uptake of COVID-19 vaccination in Liberia. Thank you very much, and over to you, Erica.
Thank you so much, Saratu. And one thing that always jumps out at me about the Breakthrough ACTION Liberia work is the really creative integration with malaria, because I think that that's an area that not everybody naturally links to vaccination, and yet it's such a high priority area in many of the countries that we've been working with. So really appreciate that. Please, everyone, remember, if you have questions or comments for Dr. Saratu and the other presenters, put them in the chat and we will revisit them in a bit. We're going to take a quick moment to poll the audience. If you could, we're going to launch this poll. We are really curious to know, in your countries, if you have generated demand for COVID-19 and other life course vaccinations through integrated activities. This is an anonymous poll. We're just looking to take the temperature of our partners today. So you have three choices. It's just a yes or a no or an I'm not sure. So we'll give folks a minute to answer. And if you do have specific experiences or successes and challenges that you would like to share, please do feel free to put them in the chat. We've been trying to collect as many as examples from country projects as possible, because this is a new area for a lot of folks, and the more examples we can share and learn from each other, the better. I'm just going to give it a few more seconds if anybody else wants to respond. Okay, Anne, I think we can close the poll. It looks like the large majority of you have been generating demand for COVID-19 through integrated activities, 3/4 of participants. We have a couple who say no, and then we have about 20% who aren't sure. So I'm hoping that this webinar maybe prompts you to ask some questions if you're not sure, or if the answer is no. And certainly if the answer is yes, I hope that this inspires you to keep doing the work, maybe expand and connect with some colleagues. Great. Let's move to the next presentation. Thank you so much for participating. I'm going to turn it over to the team from MRIGHT. Lisa Oot and Stefan Mandic-Rajcevic are going to talk with us about the work that they've been doing in Eastern Europe. And I'm really fascinated by this. I think that the lessons learned from Serbia and North Macedonia are examples we might not hear about very often, those of us who primarily work in Africa and Asia. But I think they're still incredibly relevant and might really spark us to think in a different way. So Lisa and Stefan, over to you.
Thanks, fantastic. Yes, I'm going to start, and then halfway through, I'll pass off to Steph to continue the presentation. Thank you for the introduction. Yeah, we're really excited to be here to share some insights from work we're engaged in through the Momentum Routine Immunization Transformation and Equity Project on a behavioral strategy to improve immunization uptake across the life course in Serbia and Macedonia. Next slide, please. So the Momentum Routine Immunization Transformation and Equity Project is a 5-year globally funded USAID funded project. The project applies best practices and explores innovations to address entrenched obstacles in immunization and increase equitable immunization coverage. Through MRIGHT, we are working in 4 countries in Eastern Europe: Bosnia and Herzegovina, Moldova, North Macedonia, and Serbia. And today we're going to focus on our work specifically in North Macedonia and Serbia. And so our work in the region really focused on 3 main objectives. The first, to increase demand for and uptake of COVID-19 vaccination among priority populations. The second is to address mis- and disinformation through social and behavior change and media-focused strategies. And the third is to foster opportunities for learning within and across countries in the region. Next slide, please. So in order to achieve these 3 objectives, we turned to behavioral science and applied a behavior integration approach to design, implementation, and evaluation of our activities. The behavior integration approach focuses on what people must do to overcome obstacles to a behavior and designs or adapts interventions that are linked clearly to the behavior via the critical factors that affect them. Next slide, please. So we have 3 phases in our work. The first phase of our work was formative research. So in Serbia, the project collected quantitative data using the online platform Premise. And then in both countries, both Serbia and North Macedonia, we collected qualitative data through interviews with public health decision makers, immunization health experts, as well as other key partners. And then we also did focus group discussions with members of priority populations in the countries. Next slide, please. So our findings from the quantitative data collection in Serbia, that were compared to the general population, we found that vaccine acceptance was significantly lower among pregnant women and people with chronic disease. And within the group of respondents reporting some chronic disease, almost 40% were unvaccinated, while in the pregnant women population, 67% were unvaccinated. Compared to those vaccinated who had a chronic disease, those who were unvaccinated and who have a chronic disease were less likely to believe that the vaccine is safe, were less confident in health workers directly involved in vaccination processes, and they put less trust in their health providers' recommendations. Similarly, already vaccinated pregnant women were more inclined to put trust in health workers directly involved in the vaccination process and to do whatever their health provider recommended, while unvaccinated pregnant women had more vaccine safety concerns. So we're really seeing a difference among the populations, those who are vaccinated versus unvaccinated, both for pregnant women and high-risk patients, people living with chronic disease. Next slide, please. So our qualitative findings are from both North Macedonia and Serbia, and they revealed that, and this is not a surprise to anyone, but that COVID-19 is just one of many priorities in people's busy lives. We conducted these surveys about a year and a half ago, and even at that time, COVID was among priorities, not the top priority. We heard from immunization stakeholders that the priority populations for COVID-19 vaccines are the same as for flu. So elderly people, people with chronic disease, pregnant women. And so it does align with general immunization strategies, which was a great thing to be hearing from stakeholders. We learned that patients listened to their healthcare providers' advice, but that the respondents stated that they were not getting advice from their providers to get vaccinated. In addition, we learned that patients incorrectly believe that they're not eligible for COVID-19 vaccination due to conditions such as allergies or other chronic health conditions. We also heard that there's a lack of quality and reliable health information provided to patients by their providers regarding COVID-19 and COVID-19 vaccination. And then we heard from providers that they themselves had a lack of information and training from reliable sources on COVID-19 vaccines and vaccinations, and that this was really fueling their hesitancy to recommend the vaccines to their patients, particularly those that are pregnant or with chronic disease. Next slide, please. So then we move to phase 2. So using the information gleaned from the formative research, the project used the Think Big online platform to create profiles for each priority behavior, detailing barriers and motivators to adopting it and supporting people and their actors. And then based on profiles, the team developed strategies to overcome the barriers, leverage the motivators, and involve the supporting partners to encourage the desired change. Next slide, please. So based on the analysis of the qualitative and quantitative data, we identified the following elements of the behavioral profile. So with priority behaviors we want the MOH, we and the MOH want the priority population to implement. So for example, patients with chronic disease get the COVID-19 vaccine. Pregnant women get the COVID-19 vaccine. Primary healthcare physicians recommend the COVID-19 vaccine. I won't read all of them, but we had that full list. Then we also looked at supported actors who can help encourage this behavior. So the Institute of Public Health, the Ministry of Health, pharmaceutical organizations, medias and journalists. So a list of who those supporting actors are that can help encourage the behavior. And then we looked at what are those critical factors? What factors need to be considered when designing the interventions? So for example, time for counseling. Do our providers have time for counseling? Is there a legal obligation? What is the trust in institutions? What type of data is available in each country? What does trust in healthcare providers look like, et cetera? So we took into account each of those when designing our profiles. Next slide. Through this process, we came up with a set of behavioral profiles for each country. Yes, that slide, great. You can see in this table that the key populations, the interventions that we'll target with specific behaviors we wanted to address. So I'm not going to read through the whole table, but the target populations are both health providers and high-risk target populations, as the behaviors needed to be addressed on both sides in order to achieve greater COVID-19 vaccine uptake. And you will notice there were a lot of similarities between what we designed for both Serbia and Macedonia, but there were some slight nuances, and we certainly spent quite a bit of time tailoring for each country context, and Stefan will continue to explain this when we get into the intervention part, but pre-testing and tailoring in each country to make sure we're really working within the needs of each country. Next slide, please. So here's, I think, where it got really interesting. So our formative research clearly indicated that people, both healthcare providers and communities, were tired of hearing about COVID-19, and we believe that approach focused solely on COVID-19 vaccination would fail. As such, we reframed the conversation around healthy lifestyles, with COVID-19 as part of the conversation and part of a vaccination package across the life course. For example, your provider will discuss with you the importance of an overall healthy lifestyle with the chronic disease that you're living with. And then this includes getting vaccinated on a regular basis. And COVID-19 is one of those important vaccines that you need to get on a routine basis. So that was the approach that we took. So as I mentioned above, it's really a critical address both sides of the equation. We really needed to make sure that we're both designing an intervention so that communities are receiving information, but also that when we build demand, that their providers are making the recommendation as well. So we developed a continuing medical education course, CME course, for health providers, focused on providers who are working with pregnant women and 45 plus living with chronic disease. We also designed collective engagement sessions for target community populations, so pregnant women and people living with chronic disease. And the idea is to educate and create demand among these high-risk target populations so that they then visit and talk with their healthcare providers, and then the provider is able to answer their questions confidently and then recommends for them to get the vaccine, and really talks about this in the context of the importance of vaccination across the life course. So yes, about COVID, but also about other vaccinations as well. All right, so I'm going to hand over to Steph to continue the rest of our slides and take us through phase 3 and to discuss recommendations and early lessons learned. Over to you, Steph.
Thank you very much. So yeah, we can go to the next slide. The next phase was the validation of our approach. So we were trying, since we are working on something that needs to be implemented in several regions of our country, we needed to validate the approach. So we can move to the next slide. The validation of this approach included series of participatory workshops with relevant stakeholders. So as we started to work on this project, there was a relative problem with the stakeholders with their not very high interest in COVID-19. But the way that we have reframed the question of COVID-19 as part of healthy lifestyles, and the selection of healthy lifestyles, etc., needed to follow really the priorities of both our stakeholders, the patients, the health providers, etc. So the workshops focused on concept testing of key messages, the healthy lifestyles approach, how it fits with national priorities, visual symbols, etc. When we started working on this, very often we heard the sentence, nobody cares about COVID-19 anymore. And this sounded pretty discouraging, both to the healthcare providers and to us trying to implement this project. But actually what the phrase nobody cares meant that a healthy person who has already been probably vaccinated and has had COVID at least once in the last period probably is not really worried about COVID-19. But still there were populations that we have identified which could benefit from this approach, and framed with the healthy lifestyles and with specific populations who still can have a serious COVID-19 disease, hospitalization and death, and could benefit from other healthy lifestyles, then this phrase nobody cares actually was no longer valid, and this was our way forward. We have developed effective messages which promote vaccine uptake for these specific populations. And we have addressed all of the barriers that have been identified in the formative phase of our work, so that we address not only what the patient's concerns were, but what the healthcare providers' concerns were. And I would like to say here that there was also a relatively small uptake of COVID-19 vaccines among the healthcare providers, especially nurses. So our approach addressed both the healthcare providers and the patients regarding their barriers. When we did the formative part of the research, there was a big question mark whether healthcare providers would be interested in hearing a lecture or a course on COVID-19 vaccination, and what could motivate them. And one of the things that was identified as a motivator is this obligatory continuous medical education that all healthcare providers have to go through to renew their license every few years, and they collect points. So our approach was then implemented as a continuous medical education curriculum that included 3 relatively large and very compatible sections: healthy lifestyles as the wider framework, immunization and COVID-19 vaccination as part of healthy lifestyles, so as a way of taking care of our health in the same way as eating healthy or being physically active or going to regular screenings. That we have framed immunization and life course immunization into this framework. And finally, quality health service or person-centered care, because we have identified both that the healthcare providers feel they don't have enough time to work with patients in a quality way, although they are very interested to provide the highest quality healthcare. So we leverage that, and the patient's perception that healthcare providers don't really answer their questions or do not understand the actual problem behind their worries and concerns when we are discussing immunization. Also, to approach this problem from both sides, we have developed not only the continuous medical education course, which is intended for healthcare workers, but also a collective engagement approach, working with civil society organizations and community-based organizations, so that the patients would come to their healthcare providers already prepped with some basic information and maybe additional questions or reassurance they need from the healthcare providers. This way, one of the barriers, maybe the first barrier, that healthcare providers don't have enough time, was actually resolved. And we have started working on capacity building and training of local public health or health promotion practitioners to have a sustainable vaccine acceptance. Next slide, please. Yes, the continuous medical education course was formed in a way that it gives the healthcare providers not only the information about healthy lifestyles, which we were all sure that they already know. So this was used as a kind of an anchor for what they already support and what is a positive thing for them. But then an addition of immunization and life course vaccination into this whole way of thinking of healthy lifestyles and preserving the patient's health. We have focused on clear and easy to remember messages that were repeated several times during the course, in a way that the healthcare provider also, it becomes natural for them to say these messages, and that not only influences the patients, but also influences those healthcare providers which were unsure. If you remember, some of the barriers were that they themselves were not sure about the safety of the vaccine, the speed in which they were developed. Other barriers, such as not knowing if their professional association has supported vaccines. We have addressed all of these barriers in our continuous medical education course. We can go to the next slide. As far as collective engagement, we have worked on exactly the same messages, but reformatted and designed in a way that they were easily understandable and acceptable to the key populations. We have developed a whole visual design of the program, and we have tested everything with the target populations, which was a great experience not only for our partners on the project, which admittedly have never done such a process, but the positive reaction of patients looking at these materials and providing feedback, and then saying that they were never asked before what they think about messages like this, what they think about illustrations, how they could be improved, etc. This kind of improved the confidence of our partners that this program is actually meant for success. Also, it meant learning and adapting based on every step and everything that we have done. The same testing was done also for the continuous medical education course with two populations. One were the actual healthcare providers for which the continuous medical education course is intended, that work with these key populations. And they also said that they were never included in such a session where they could provide feedback and say what was relevant or not relevant for them in a course like this. But also it was tested with public health professionals, which would deliver this kind of training for healthcare providers, and they themselves could also provide feedback and improve our training. Next slide, please. So what have we learned to date from this programming in Serbia and North Macedonia? We can go to the next slide. It's really important to be creative in using available data and evidence when we are trying to produce programming, and also to fill gaps with targeted research. When we did our formative research, there was already a lot of data available. There was a lot of knowledge among our stakeholders that they provided, but it was really important to identify actionable points from their information, and maybe in the future meetings to remind them that they were actually those who provided the data and actionable insights for us to develop the course. This way, they felt that their opinion was listened to, and that the program that was developed is actually based on their needs, which it was. Also, we used specific data collection moments where we tried to fill the information voids so we could identify barriers, motivators, and key supporting actors so that we developed this program. We used a very good decision support tool, which was the Think Big platform, which helped us make sense of all the behavioral data that we collected to identify clearly what are the behaviors we want to influence, to put the barriers and motivators in an orderly fashion, and then based on these motivators and barriers, identify key actors and their actions and the strategies that could either leverage the motivators or reduce the barriers that we have identified. The platform helped us do this process while also showing a very clear theory of change that was implemented in our program. Our strategy was validated before implementation, and then when we started the implementation, it was revalidated several times, because every time there was a new discussion with a new group of healthcare providers or patients, they were actually repeating the same barriers and motivators, and we could see through their opinions that we have used the data wisely and developed a strategy and validated a strategy that could be implemented in the best possible way. We were aware that the vaccination is also just one of many technical areas where both healthcare providers and communities see issues. So we have tried to frame our program in the best possible way that it's acceptable for the healthcare providers, for the patients, but also for our stakeholders, such as the Ministry of Health or Institute of Public Health, which in general are trying to improve the health of the population, regardless of COVID-19 or other issues in a more general way. So our program fit very well with that. And also for being able to continuously use this program, we have worked with our healthcare providers and with our stakeholders, explaining to them that they could adapt this program for their other needs at a time when COVID-19 maybe will not be an issue anymore. And then it's really important to continuously collect data to inform and adapt the program. And we have used several streams of data collection in our monitoring, evaluation, and learning process, where we collect data from healthcare providers, from the patients, where we organize learning exchanges with the persons implementing this training, which helps us address the potential issues even before they become an issue. Next slide, please. At the moment, I can say, well, I have just looked at the data that our colleagues exported for me, and the percentages don't change a lot. So the training definitely improves the knowledge and understanding of the participants on COVID-19 vaccines and healthy lifestyles, and how to provide quality client services, which improves the satisfaction of both healthcare providers and patients. That's the same for Serbia and North Macedonia. The way that the training is presented is seen as really positive, and case studies and role plays and self-assessment quizzes are those that help the most in this process. And the participants feel really confident in applying what they have done. And I'm really under impression, because I just returned from one session of training of trainers, where we have trained another set of people from institutes of public health in Serbia, and from a learning exchange where we have heard really positive feedback from the people that have been implementing this kind of training in the field, but also from our partners who are doing collective engagement about how the patients see this approach when they work with this. And just to finish off with a funny comment, even patients who have been vaccinated, when they see that there is a workshop for those who haven't been vaccinated, they ask to participate, and they feel that they could benefit from the healthy lifestyles approach, although the actual target is immunization. We can go to the next slide. I will not go through this slide in detailed manner. There have been many community members now already trained in North Macedonia and in Serbia, according to our new data, and we're expecting to have more than 100 community events, probably by the end of this month or by the middle of October. And another encouraging data set that I received this morning is about the number of trained healthcare providers, which is already more than 100 in North Macedonia and almost 200 in Serbia, although we have been implementing this for just 1 month. We can go to the next slide. Yeah, thank you very much for your attention, and we are really open to any questions.
Thank you so much, Stefan and Lisa. I mean, something that strikes me is that we went from Liberia to Serbia and North Macedonia, and yet so many of the barriers and the reasons for hesitancy and the misinformation is really similar in contexts that we might not otherwise think have a lot in common. And I suspect that some of that may be true as we board our plane and head over to India. So we're going to move over now to Dr. Solomon, who works for the Core Group Partners Project in India, and talk about some of the work they've done integrating COVID-19 vaccination into polio and other routine immunizations in their projects. Dr. Roma, over to you.
Yeah, thank you. Can I have the next slide, please? Yeah. So we've been working for 24 years on basically raising the demand for polio vaccination. You may not know that there was a lot of resistance to the OPV, the oral polio vaccine, in the beginning in many parts of the country. There was suspicion that it was a family planning kind of a pill. And so we've been working with those communities for 24 years. Earlier, we were known as the Core Group Polio Project. Now we are known as the Core Group Partners Project because we've diverged. We're doing other things as well. Next, please. Yes. So we have been communication partners with the government in polio eradication. And we are also supporting routine immunization in children and tetanus toxoid in pregnant women. And as luck would have it, bad luck would have it, we never knew that we were going to start promoting COVID vaccination. We were sort of coming to the end of our project when COVID appeared on the scene. And we had to go through all the steps all over again. Next, please. Yeah. So our traditional strategies for demand generation, we were doing that through community mobilizers, which we had picked up young women from the same communities who slowly became very strong. Initially, they were hesitant, but as vaccine hesitancy grew, I think they picked up strategies on how to tackle that kind of hesitancy, tackle rumors, and they became very, very strong. And what we were doing right from the beginning was to strengthen communication capacities of government frontline health workers. Ours is a project, and we were not going to stay forever. We never knew we were going to stay for 24 years, but we have put in a lot of communication capacity building into our government frontline workers. We basically worked on interpersonal communication skills. We have made a lot of communication tools to conduct in meetings with the communities, and development of area maps and due list preparation for the ANMs, for the auxiliary nurse midwives who give routine immunization vaccines. Next, please. Yeah. I'm giving you a little background of what we've done for polio and routine immunization, because this is how we sort of readied ourselves for we never knew the pandemic was coming. But we also involved a lot of influential people in the community. There was a lot of involvement of schools, of school children. They made excellent mobilizers. And also we did a lot of mid-media activities. You can see here one of the e-rickshaws that are quite a draw. And you can see brick kilns. India is a country where during some season before the monsoon start, a lot of brick kilns come and we make bricks. And usually these whole villages move into these brick kilns to make these bricks. And earlier they used to be sort of left out of immunization because nobody they don't carry immunization cards and stuff. But for the polio program, we brought them in. We brought many hard to reach populations in. We worked with migrant communities that sprung up overnight, agricultural labor and all kinds of people like those, nomads. And this is what we've been doing for polio and routine immunization. Next, please. Okay, so for adults, the only good adult vaccine was the tetanus vaccine, which was being given to pregnant women. And our coverage was very high in that. But now what happened was, COVID came. Initially, people took it very lightly. Like the other presenters have said, it's like a cough and cold, it'll go away. It was only when it started getting serious that, initially there was a lot of hesitancy about the vaccine. We make our own vaccines. As you know, India has provided a lot of vaccines around the world also. So vaccine was not a problem, but when it came sort of unannounced like COVID, the same kind of hesitation came up as we saw in the other countries. Is it safe? And social media, went to great lengths to come up with all kinds of absurd conjectures about the vaccine. Like you'll be dead in 2 years. Bill Gates is putting 5G in the vaccine, which he's injecting into people. It causes HIV/AIDS. It just went on and on and on. But when people saw that people were dying, they really got scared. And what we did was, we had a lot of influential people who helped us during the polio campaigns over the last 2 decades. We formed those influencers into community action groups in each village. What used to happen was that anytime a patient, a person in the village would get, or in the city would get COVID or signs and symptoms of COVID, they would send a police van in the middle of the night or an ambulance with a siren blaring just to pick up that person and take him or her to the hospital or to the those kind of centers that they had made. Now this instilled a lot of fear into people, and they started hiding cases. They wouldn't tell people. And so we formed these community action groups led by the village head, who would call up these people and say, talk to them over the phone and say, you don't worry, this is, they're going to look after you, and we will provide you with all essential supplies. And there was a lot of telephonic counseling going on. These our mobilizers trained them. We had laid off our community mobilizers in 2020, when polio had gone for some time and routine immunization was doing well. But when we called them back for COVID, they all agreed, and most of them said, we're already working in the communities for this, against this dreaded disease, and yes, we'll come back, and yes, we'll work with you. And we trained them over the phone, and they in turn trained their government frontline workers. They formed these community action groups, which were led by the village head. Also, we would have a government frontline worker in this. We would have a religious leader in it. We would have a local doctor, one of those, even those Ayurvedic doctors or from traditional medicine practitioners. Any influencer who had some say in the community, we formed them into community action groups. These have become very, very, very popular and very effective. Because the moment they hear of somebody refusing vaccine, or somebody getting COVID, or somebody spreading false rumors, they spring into action. The other thing was that, yes, and then the other people we involved were barbers. We used them for polio as well, for immunization as well. Because as you know, that barber shops are one places that men have to keep quiet. They have to listen, unless otherwise, they'll get cuts on their faces or wrong hairstyles. So we trained the barbers. We had already trained them in routine immunization, how to talk to people. As you can see in the photo, the barber is asking the guy, have you taken your children for vaccines? And he'll say, no, I'm scared, or I don't have time. And, then they would start talking to them, and, the things that could happen if the child falls sick and, could die and things like that. So we use the same barbers to spread positive messages on COVID vaccination and on other, COVID appropriate behavior. We also had tea shop meetings. There are a lot of tea shops in India, in villages, in cities, where people sit under trees during their break time and sit and have tea or just chat around. And these were these places we sent our mobilizers to talk to them. We had meetings with fathers. And you may be aware that the government came up with an application called CoWIN. And CoWIN was accessible to all. It was connected to vaccines, to the COVID vaccination. And all one had to do is to pick up their mobile phones or somebody else's mobile phone and register on that COVID app for their first dose of vaccine or the second dose of vaccine, and then they would be reminded for their second dose, or where to come, or if there was an adverse event, they could go back on the app and see where they could get medical help. So there was slowly resistance to the vaccine turned into acceptance because it was so well organized, and people realized that people were not dying of the vaccine as much as they were dying of the disease itself. And so this is how we sort of slid into demand generation for adults for COVID. Next, please. Okay. Basically, what we do is when we talk to the community, to people, to women, to men, to anybody who cares to listen, or who the influencers, we make them understand the science behind vaccinations, behind the vaccine, through no-cost indigenous tools. If you take two empty glasses, and this is two children, and then one child takes a vaccine, the other one doesn't. You put a little water into one glass, and then the other one remains empty, and then you bring another vaccine or a next dose of the vaccine. So the glass keeps filling up. The child gets more and more resistant to all these diseases, whereas the child with the empty glass remains susceptible to vaccine preventable diseases. So this just no cost tools, which become very easy for people to understand. So we find a little good audience for that, and each person who listens to us at these tea shops or in women's meetings, religious gatherings. We also used a lot of religious gatherings, especially among the Muslims, because the Muslim ladies go house to house. It's like Bible classes in families, in homes. So they go house to house teaching the Quran, and we ask them also to spread this message that this is a very dangerous disease, and please make sure that all adults are vaccinated. As somebody else in a previous presentation had said, that initially, because the vaccine was not being given to pregnant women or lactating women, so when it was given eventually, there was a lot of reluctance and people were scared, but slowly we worked on that also, and then everybody was taking the vaccine. For the first dose of vaccine, we in core group, we were able to reach almost 4 million people, adults, for COVID vaccine. Next, please. Okay, so as I told you, we contributed to the government efforts in successful elimination of polio. So we were able to do a response to the pandemic, and also catching up of immunization coverage. What happened was, because of COVID and because people were too scared to bring their children out for to the immunization sessions during COVID times, and there were very few sessions were being held, a lot of children had missed their routine immunization. So we had to catch up on those as well. Measles, rubella's campaigns coverage also we had to deal with, because 2023, this year, by the end of this year, we were supposed to have eliminated measles and rubella. It doesn't seem like it's going to happen, but we had to work on that. And as vaccination of 0-dose children, the children that were left out during COVID, we had to contribute to those efforts also, along with adult COVID vaccine promotion. Next, please. So that's it. We did a lot of things. We made a lot of IEC material, which we shared with the government. And because we were very well known in the communities as having taken polio vaccine to them, it wasn't so easy. But now the government plans to also introduce in phases the HPV vaccine for adolescents. So that is going to be quite a challenge, and let's see what we learn. What we've learned from COVID vaccine promotion, I hope we can use the same kind of approaches for the other adult vaccines to be coming up. Thank you.
Thank you so much, Dr. Roma. There's one very quick question for you, Dr. Roma, which is just, would it be possible to share a document or link or examples about those no-cost indigenous tools? I think others are interested in learning how to do that.
Certainly, I will do that, but maybe not today. Yeah, but I'll send that to you.
If you can share it with me, I'll be happy to share.
Yes, certainly.
Great, thank you.
Yes, thank you.
So I want to thank all three presenters. We only have a couple of minutes remaining, and I want to be respectful of everyone's time. There was one, I think, really interesting and important question in the chat that I would like to put out to all of the panelists, which is, how do we synchronize this demand creation with service delivery and vaccine availability? I think there is concern about, of course, wanting to create demand and making sure that the right vaccines and services are available to meet that demand, or we will lose those folks. And of course, the flip side is, if there isn't demand and there is vaccine availability, we're wasting vaccines. And so curious what any of your projects have done to try to synchronize those elements. Are any of the panelists interested in taking a stab at that question, Saratu?
Yes, I think I can share our experience here in Liberia, because we also had those challenges that we were dealing with. So it was to ensure that everyone was part and parcel of the coordination platform, even for the demand creation and the risk communication and community engagement pillars. We ensured that there were times that we would have conversations with the service delivery partners so that we could synchronize our plans and align our plans. So for instance, in sharing communication about the vaccine, we worked with the technical groups to get the national guidelines, which was communicated through the communication pillars and the risk communication pillars. Then we supported the rollout of vaccines by ensuring that demand creation timelines were in alignment to those community vaccination mobilization exercises, in such a way that we would plan the demand generation and mobilization exercises to be before, during, and after. We've had instances where during the rollout, we've had to deal with inadequate supplies of vaccine, or the vaccines did not arrive at the location on time. So making sure that you were in constant communication with your partners on the other side of the table ensured that, we were not breaking that trust with the community members, but that they were clearly aware of how to get services, when to get services, and from who to get those services from. Thank you. Over to you, Erica.
We did the same. Thank you. All the time we actually work hand in hand with the service delivery people of the government, because there's no point in working yourself, because when the project is over, then you just leave. So we basically make sure that we sit in with these people, we talk to them, we share our tools with them, so that when we are not there, and then they start doing the same thing over and over again. And once they make friends with the communities, it's easier to introduce the next vaccine. I think COVID was quite an example. People got very, very scared and terrified. So hopefully whenever, more and more adult vaccines are introduced into the routine government system, people would not be so against them. Thank you.
Thanks, Roma. Stefan, did you want to add? You're muted still.
Yeah, I pressed it once, but then again. So anyway, I wanted to share our experience and approach with trying to address everything at the same time, which is nearly impossible. But this is why we brought our trainers to be of local institutes of public health in each of the districts, of the countries where we work. And this approach helped us first make sure that the population is informed if and where which vaccines are available, and that's something that can differ from district to district. But since local Institute of Public Health people were included, were actually the trainers of healthcare workers, they had this information and they could share directly this information. Then for the information environment, which was one of the, let's say, barriers, because people read various things in the news, we worked with the journalists in developing a course on vaccines, which healthcare journalists could easily take. But also we have developed a group of nationally recognized experts in Serbia, which made themselves available to answer any questions that journalists would have. And that would really echo throughout the country, through national media, right in the right moment. So, for example, when the bivalent vaccine for COVID-19 became available, we organized, as a project, we organized a press conference with really the most prominent immunization and experts, and they offer data on the new vaccine and why it's important and to whom it's recommended. And then when we did the training of our trainers so the IPH people, those same experts came there and answered their questions. So our trainers felt really confident in doing this training with other healthcare providers. And finally, and I will stop here, our community-based organization that we work with is actually an organization with more than 20 years of experience, really recognized in the community as working in the area of HIV, STDs, working with poor communities, etc. And they use their network of volunteers, which have been very well trained, to work in the community, but also we have connected them with the IPH people, so they had the right information at the right moment, and we created an environment where there is a lot of communication going in the right direction, and everything works better than expected. Let's say it like that.
Great, thank you so much. I want to just move us on to a few final slides so that you all know how we will be sharing resources with you moving forward. So Knowledge Success has been collecting and publishing a lot of integration-related resources. We're going to put a link in the chat to our Knowledge Success COVID page where you can find all of those resources, but I'll share in particular that we have a series of 4 essential resource collections on various topics, including reaching high priority populations with COVID-19 vaccine, data management and digital health, resilient supply chains, and integration. Each collection has about 20 resources that we really think are your go-to resources in one location. Next slide. We've also published a 7-part blog series on integration, and many of the examples actually that you heard in more depth today have been covered in some of those blogs. We encourage you to read up on those and learn about what other projects have been doing in this space. And lastly, we are in the process of preparing a supplement for the Global Health Science and Practice Journal that is specifically about integrating COVID-19 vaccination into primary healthcare. We have a number of great papers in the works, and this is scheduled for publication later in December. We will be sending out announcements. If you do go to that Knowledge Success COVID-19 page, you can sign up to be on a newsletter for any forthcoming products. We'd love to be able to email you about those. Next slide. We will also be sharing today's recorded presentation and the slides and a link with all of the resources for you. I really want to thank again our speakers from UNICEF, Breakthrough ACTION Liberia, MRIGHT, and CGPP for those really creative and thoughtful presentations. I think we've all heard the same message that Stefan shared earlier, which is that a lot of people are just sort of done with COVID-19. Clearly, COVID-19 is not quite done with us, And I think that our creativity and understanding the nuance of that barrier is going to help us continue to integrate this into the primary healthcare system, as these groups today have shared in really successful ways. So thank you, presenters. Thank you, participants. Really look forward to connecting with you in the future and continuing this work. Have a great day.
Bye, everyone. Have a great day.
Thank you.
Yeah, thank